All right, well, we'll go ahead and get started with the next presenter. So I'd like to welcome Dr. Jessica Hutchins. Dr. Hutchins is a pediatric endocrinologist at Atrium Levine Children's Hospital in Macon, Georgia. She completed medical school and pediatric residency training at Mercer University School of Medicine here in Macon. Woohoo! She completed her pediatric endocrine fellowship at University of Texas Health Science Center in San Antonio, Texas in 2016. After fellowship, Dr. Hutchins wanted to come back to practice in Georgia and was able to start at Children's Healthcare of Atlanta. She decided to come back to her medical home in Macon in 2019 to serve the patients of Middle and South Georgia. She enjoys seeing a variety of endocrine patients and enjoys using all the new technology for her patients living with diabetes. She serves on the board of directors for Camp Kudzu, a type 1 diabetes camp, and actively volunteers at a summer camp and other events throughout the year. She is actively involved in training Mercer School of Medicine students and pediatric residents. Welcome, Dr. Hutchins.
Thank you. Yep, making sure that all worked like I was supposed to. All right. Hello, everybody. I know y'all are probably all tired. It's the end of the day. Y'all had lunch, snacks, all the things. So hopefully I can keep y'all engaged. Like you said, I'm Jessica Hutchins. I'm glad to be here. I've met some people at other events before, and obviously some of our local people. But for anyone here that doesn't already know me or hasn't already talked to me, after the talk, please feel free to come up to me if you need my number to, run a patient by me. Those in the audience who already do that know that I will respond and help when needed. So just throwing that out there. I am I am a paid speaker for Sanofi, and that is educating pediatricians about screening for type 1 diabetes. And then, as he mentioned, I do sit on the board for Camp Kudzu, which is a type 1 diabetes camp that I started volunteering at before I was even a physician. And this is a volunteer position. So I'm not paid for that. I donate money in my time. So objectives today, the way I'm going through this is actually just going through actual patient cases. So people that some of y'all may have referred, obviously their names are in there, but just wanted to use real scenarios to show you the referrals that we're getting, what I do, and help empower you to feel comfortable what you can monitor or manage versus what needs to be referred to get proper treatment by an endocrinologist. So we're going to do recognizing and evaluating disorders of puberty, assessing causes of short stature and when to refer to us, analyzing common thyroid abnormalities, and knowing when to screen for type 1 diabetes. So we'll start with early puberty. That, I don't know if y'all have seen it, but we have seen it in endo since COVID. I don't know what happened during COVID, but precocious puberty is like booming. There's articles written about it in our literature. It's not always true, central precocious puberty, but just early pubic hair, early breast development is very common now. I'm sure, with all the data about the endocrine disrupting chemicals, plastics, all the environmental triggers and things in our food, I'm sure contribute, but we have been seeing a lot of it. So, and I know y'all have because y'all refer. So this was a patient I actually recently saw, a 7-year-old with breast development. This screenshot of the growth chart was from the pediatrician's referral. So mom had noted breast buds starting in the last few months. She had minimal pubic hair, no signs of menses, otherwise normal, healthy kid. Exam showed Tanner 2-stage breasts with a few strands of pubic hair. Her mid-parental height, so basing off mom and dad's height, was 25th percentile, but she was now tracking at 75th percentile. And y'all can see that sharp increase that last year or so that she really took up in her growth velocity and growth percentage. And so when I saw her, I did labs. So LH was 1.2, which is pubertal, and LH above 0.3 is pubertal range. And her estradiol was 14. 14, technically above 20 is pubertal, but the LH is really what clinches the diagnosis for me. If the LH is above that 0.3, then that tells me this is central precocious puberty. Y'all may remember back from like early med school or for NPs in your training, the puberty hormones kind of have a pulsatile secretion, and they fluctuate. The morning hours are when they're the highest, and so depending on what time of day you check these labs, they may look normal, but that doesn't mean they're not in central precocious puberty. You may have just not caught them at that time. So Did her bone age. Her bone age was 10 years old. She was 7, so her bone age 3 years advanced, and that kind of correlated with that huge jump in growth velocity that we saw on her growth chart. So in her case, I did diagnose her with central precocious puberty, and I started a GnRH agonist. Most of them now are every 6-month injections, and it is an IM injection. Some of the pediatricians who live really far away, sometimes they may come to your office for these injections. The reps with these companies are really easy to talk to if any of your staff has questions. One of them is really easy. Another one, it's like the mixing is a little bit more complicated. And so if ever you have questions, if they are getting it at your office, let us know. But the companies also do offer a home health that will come to their house and give the shots. So sometimes we arrange that for our patients who live far away to help accommodate the transportation. So case 2, this was a case that came in with premature thelarchy. This was a 4-year-old. She presented to their PCP with left breast bud. So this growth chart, it actually shows an epic of sometimes if our charts link, I can pull in from the pediatricians. So the little asterisk plots are from the pediatrician's notes. Obviously, the one way at the bottom was probably some random sick visit that got mislabeled in the height. But the solid dot was the one at my office visit. So you can see she's kind of always been tracking tall. No clear increase in growth velocity like we did in our prior case. Otherwise, on exam, like at the pediatrician's office and in history, no other signs of puberty, just that left breast bud. The PCP had actually already done labs. Estradiol was undetectable. The LH was 0.2. So like I said, 0.3 and higher is concerning. FSH is 1.8 and prolactin 6. Both of those are normal. The FSH really honestly doesn't really help us much. Their ranges of normal are very broad and a lot of them cross over as far as pubertal and not. So really, like I said, the LH is really the diagnostic thing that I'm looking at when I'm diagnosing central precocious puberty. Again, growth chart showed steady growth rate. They made the endo referral. And then by the time I saw her, I'm not sure what the time, I don't remember the time difference from the referral till when I saw her, but the breast bud was gone. So that little left breast bud had regressed. Mom still came to the appointment because she was still, had been nervous about it being there. But it was gone by the time she came. So, and this patient, this could be one, especially for people who live really far from us. If the parent isn't super worried, one little breast bud, it just started, growth velocity looks good, the labs are reassuring. You could just say, hey, you know what, come back in, a few months, 3 months, 6 months, let me just watch it. And then if it goes away, then call us and cancel the appointment and not have to refer to us to save them a trip, a trip to the specialist. So another thing too, if you don't want to stick them, then a bone age is always easy to get. It's non-invasive. And that's also another quick tool. If the bone age is normal, it just started, growth velocity is normal, especially no other signs of puberty, then again, that could be an easy one to say, hey, just come back in a few months. We'll watch it. If it keeps progressing, then we can do the referral to endocrine. But, you can frame it to the parent that it's okay. We can, I have this and trying to save you the trip to drive up to Macon or down to Macon, whatever way they're coming from. So. And then premature adrenarche, which is another common one. So this was a 5-year-old with pubic hair. This was her growth plot. So kind of has been steady for a while around the 50th percentile. On exam in my office, she had Tanner 3-stage pubic hair. I did not appreciate any clitoromegaly. She had no other signs of puberty, so no breast development or axillary hair. Growth chart, again, like I said, showed a steady growth rate. Her bone age was actually about a couple of years advanced. So she was 5 years, 8 months, and the bone age was 7 years, 10 months. And labs, the big things I'm screening for in premature adrenarche, I usually want to grab the 17-hydroxyprogesterone, a DHEAS, and a testosterone. That I want to rule out late onset congenital adrenal hyperplasia because these patients do present with premature adrenarche. So that's why we want to get the 17-OHP. The DHEAS, oftentimes you may see that it's a little bit elevated. So the 33, technically for a 5-year-old is slightly over normal, but she has Tanner 3 pubic hair. So actually for Tanner 3-stage pubic hair, the DHEAS could actually be almost 100 or slightly over 100. So what I often see in these premature adrenarche patients is that they have a slightly elevated DHEAS, normal testosterone or suppressed testosterone, 17-OHP is normal. And the DHEAS is usually in the range for whatever Tanner stage pubic hair that I see on exam. And then oftentimes their bone age can be 1 to 2 years advanced, and that's still technically within normal range for pure premature adrenarche. So the big thing in these patients is if they have the bone age advancement, is that they could push them into true central precocious puberty. So now her bones are 7 years, 10 months. Technically, once you turn 8, if you start getting breast buds, that would be normal. So if she's 6, but now her bones are 8 and she starts getting a little breast bud, she's still 6 with a breast bud. And now that may have pushed her because her pituitary is knowing like the bones are this age, not what her chronological age is. And so that's for these patients, it's more so monitoring to make sure they don't actually push into central precocious puberty because of the advanced bone age. And then also the bigger thing is ruling out the CAH. But if they have a normal bone age, growth has been normal, you just see a little pubic hair, you may not even do the labs if you feel like there's no clitoromegaly. It's very, Tanner 2, maybe Tanner 3. I'd be a little nervous. Tanner 3 on a 5-year-old. So, but if it's just like a few, some parents come in like literally like 2 strands of pubic hair and they're freaking out. So, they come to my office and they're like, well, 1 strand already fell out. I'm like, okay. So, it happens. I also get asked like, can I trim it? Can I do this? I'm like, you got to do what you got to do. Because unfortunately, even if you have central precocious puberty and you have breast and pubic hair, if I give you medicine, that doesn't stop the pubic hair. That just stops the breast and the period. So the pubic hair will continue to be there. So sometimes that obviously irritates the kids. But so for these patients, it's just me watching to make sure they don't go into central precocious puberty and again, ruling out the CAH. These labs also are better to be done in the morning. Again, sometimes if they're there in the afternoon, you have a captive audience, if they may live 20 or 30 minutes from you, because if you're in rural Georgia, so you just grab them when you can. If they have late onset CAH, that 17 OHP, it's probably going to be high regardless of the time of day. So, but just to kind of give y'all understanding of what I'm thinking of when I see these patients and what I'm looking out for and what I'm worried about, and when to be like, okay, this is still okay, and I can monitor this for now, And some of the parents, you notice it and they've seen it and they weren't even worried about it or never noticed it themselves, depending on how old the kid is and how much they help them in the bath. So. This chart is just a little good differential diagnosis. The other of early puberty, lipomastia. So again, with our obesity increase, sometimes it's hard to know, like, is this breast? Is this fatty tissue? The parent will say, oh, they have breast tissue. But when you go to feel, it's just fatty tissue. It's not true glandular breast tissue. And so for those patients, obviously, you just obviously educate diet and exercise, but they don't obviously have to see us. If they have signs of precocious puberty, but it's been, sometimes parents will be like, oh, they've had that pubic hair and nothing's changed, or they had those breast buds and they haven't increased or gone down and it's just staying the same, it's not progressing, then usually that's reassuring and that could be one that you could kind of monitor. But again, if they have more than one signs of early puberty, like breast and pubic hair, then more than likely you would probably want to send to us just to make sure we're not missing anything. Again, the premature adrenarche. If everything looks okay, slight advanced bone age, slightly elevated DHEAS, everything else looks good, you could monitor that if you feel comfortable. If not, send them our way. The thelarche, y'all probably know, 2 and Lunder, it's very common to get premature breast development. And so usually those don't need an endocrine referral. Obviously, if it's progressing really fast or there's other signs of puberty, then call us. When I was at CHOA, I had a pediatrician call a 6-month-old that had Tanner 3 breasts and vaginal bleeding, and obviously was freaking out. And she ended up having McCune Albright. So she had the big cafe au lait, coast of Maine, on her back. And so that one ended up being a very interesting one. On that one, those patients are peripheral precocious puberty, not central. And so the pediatrician had done the labs. The LH and FSH were completely suppressed, but her estradiol was like 600. And so those patients, but still present with early puberty. So obviously, at 6 months, definitely send our way. And then these precocious puberties patients also looking for those, like that cafe au lait spot, especially in someone that young. And the one for McCune Albright, it's like on one side of the body, it doesn't cross midline. It's usually very big, and they call it the coast of Maine. So it's usually very obvious. Not to miss it. And the other referral that I get sometimes is prepubertal vaginal bleeding. And so they had an episode a day or one time of vaginal bleeding, no other signs of puberty, no pubic hair, no breast. So in those patients, usually if they have no breast, that's not probably going to be me. Usually I think of trauma, infection. You could get a pelvic ultrasound just to look, obviously, if there's like a foreign body, if the uterus and ovaries are normal size, and we know they're not being stimulated. But on my end, if you are having vaginal bleeding from a period, you would have breast development, unless you had some thing, which could happen at congenital like absence of breast tissue, but that would be very rare to have that along with vaginal bleeding. That was true precocious puberty, but just that be rare. But so those patients oftentimes may be better to go to like pediatric GYN if we think we need to do, a more thorough exam, and obviously doing screenings for UTIs, STDs, because obviously sexual abuse is also in that differential if they have vaginal bleeding before puberty. Are y'all going to send out these PowerPoints? I wasn't sure, because this was also like a really good flow chart about just when you're working up precocious puberty. So if not, I can email people this, but I'm not going to go through it all. But it was just a good flow chart to kind of go through the labs and when to order things that I wanted to kind of keep in people's minds. So the next thing is delayed female puberty. So this patient was referred, she's 14, for primary amenorrhea. And if you look at her growth chart, she's always been on the shorter side, but pretty consistent growth velocity. The little mark on the side of the growth chart is the mid-parental height. And so you can see she wasn't going to be very tall just based off of her parents' heights. Breast started about 1 year ago. Her exam showed Tanner 3 breast and pubic hair. Her bone age was 11 years old. And so her bone age is very delayed. So if you think about it, Tanner 3 breasts and pubic hair for an 11-year-old would be pretty appropriate. By 14, usually a lot of times you'd be thinking they would have had their cycle by now. And so in her case, I just said this is delayed puberty and that she's just got constitutional growth delay. Obviously, she was short and had delayed puberty, but given where her height is now and her mid-parental height and her bone age is 11, she still has a few, 2 or 3 more years to grow before her growth plates fuse. And so she'll be able to catch up to that, final predicted height where her family was predicting for her to be based off of their heights. In this patient, at this point, I just said, you're fine. I don't have to see you again. It's just your bones are delayed, so that's why you're not having your period yet. Obviously, if it doesn't come in the next year or so, then you may have to come back. But given that she already had Tanner 3 breasts, more than likely her period probably was going to start soon. Height-wise, again, looks like she'll be fine. Always in the back of your head, short, delayed puberty, always be thinking Turner syndrome. Obviously, in this girl's case, because she was growing so well, I didn't think it was Turner's. Turner's mosaic can also go through puberty. So having breast development does not exclude the diagnosis of Turner syndrome. So if you have a really short girl and she has breast, doesn't mean she doesn't have Turner syndrome. So, and sometimes the mosaic Turners also don't have a lot of the physical features. And so it can be a little bit of a red herring. So when in doubt, I just check the karyotype just to make sure I'm not missing anything, because they have so many other things that we have to look out for, heart, kidneys, they're at risk for thyroid, celiac, and, a bunch of other things that we want to make sure we're monitoring for. So this case, this was a 16-year-old. So I will caveat is this is the PCP's growth chart, because they originally referred when he was younger, and then the mom never showed up. So if you look at his growth chart, the weight that's on this far side, he was around 50th percentile and slowly had dropped down, but it never went below the chart. Whereas his height, he was at 50th and again slowly kept dropping, and more recently, kind of around 12, kind of started falling under the chart. So if you think about it, compared to his peers, that's when they're all going through puberty, so they're getting that growth spurt. And then if he wasn't in puberty because it's delayed, he's kind of trailing behind compared to his peers. So again, kind of a short stature and delayed puberty picture like the girl before. On my exam, his testes were about 6 cc's, minimal pubic hair, and obviously the short stature. I did his bone age. It's 12 and a half years old, so he's pretty far behind on his bone age, which 12 and a half and 6 cc testes, that's about right. He's, early in puberty. I don't know if anybody has the little Prader beads for testicular size. You can buy them on Amazon. They're like $20 or less. But the first 3 sizes are pre-pubertal, and then 4 cc's and above are going through the different Tanner stages of puberty. But it's good to have sometimes when you're doing an exam, because for boys, their first sign of puberty is testicular enlargement. And so without those beads, sometimes if you're palpating their testicles when they're kind of still small but starting, you may not even notice that they already are going in puberty, but because they're not going to have pubic hair initially. So that's just an early sign. And usually the parents aren't going to notice that because they're not obviously palpating testicles, unless you have a pediatric endocrinologist mom and always being like, oh, what's going on? And the pubic hair will come later. So just something to be thinking about. Like I said, those are cheap. Labs, so he had normal thyroid. His IGF-1 was 187, which for, usually would be a little bit higher. It wasn't undetectably low, but for his his age and even his bone age, I would expect it to be a little bit higher. CBC, CMP normal. Testosterone was 90. So, I mean, it is showing he is in puberty. He's starting to make testosterone, and his LH was 1.8, which is also pubertal level. For him, because of how poor he had been growing, in the delayed bone age, I did do growth hormone testing. I officially have to do growth hormone stimulation testing to diagnose growth hormone deficiency. And also for the insurance to cover the medicine. And so I did do that testing, and he did fail the testing, so he is growth hormone deficient. And then in his case, the delayed puberty is really, relating to the growth hormone deficiency, the delayed bone age. And so I'm waiting for him to get his MRI. I have to do an MRI before I start growth hormone to make sure that he doesn't have like a tumor in his brain or something that's causing any of this. Usually not the case, but I don't want to give someone growth hormone if there's something big in their head that I don't want to grow. So, again, this is another little flow chart for girls, delayed puberty. If they haven't had any breast by 13, maybe start thinking about it. Boys, 14, if they don't have any signs of puberty. And then just starting LH, FSH, and either testosterone or estradiol. If for girls, especially if you see like the LH, and boys too, but LH and FSH high, but no estrogen, that's where like if it was a girl who was short, then Turner's really should be, in your head because it's the lack of the estrogen production for girls. So if the LH and FSH are up, their pituitary is trying to stimulate their ovaries, and the ovaries aren't responding since they're not working, or their streak gonads. So, and then vice versa, if their LH and FSH are really low and their testosterone, it's meaning it's originating from the pituitary. It could just be, again, if they're short and have a delayed bone age, it may just not be time yet. But if, you have a 15-year-old girl in front of you with a normal bone age and she's still not showing signs of, LH and FSH or any puberty, you would be concerned something else was going on and have to do more of a workup too. Short stature. So both of those were a little bit of short stature, but these are just some more just short stature that we see commonly. So this patient was a 14-year-old male referred to us for short stature, and he was also lean, poor weight gain. I didn't include the weight chart, but he was just like always kind of skidding around like the 5th percentile for his weight. The first two plots were the pediatrician, and then after that was from our office. And so when we initially saw him, he had Tanner 2 puberty, so he was just starting puberty. His bone age was 2 years delayed, and did all his labs, IGF-1, thyroid. I often check celiac too, because he also had poor weight gain, just to make sure we're not missing any kind of chronic inflammatory process and absorption issues. And then as you can see, the most recent growth velocities have been increasing. And so when we first saw him, I said, hey, bone age is delayed. His mid-parental height is 50th percent, so he wasn't, too far off. Let's just see, this looks like just constitutional growth delay. The prior pediatrician's height, he'd always been tracking small. And so based on that, I told Mom, I think this is just constitutional growth delay. I don't think we need to do growth hormone testing. With boys who are short and starting puberty, once they're at Tanner 3 puberty, if you have some of our patients, you may see that I have them on an aromatase inhibitor. So which normally they use in women's with breast cancer to decrease estrogen. But if you go back to, training, aromatase converts testosterone to estrogen. Estrogen is what advances your bone age and eventually closes your growth plates. And so what we do in boys who are shorter, and I'm trying to basically just buy them time to grow and not let their bones fuse. So if they do the aromatase inhibitor, they go through puberty, they're making their testosterone, but they're not converting to estrogen. So it keeps their bones open longer, and it just gives them more time. So it's not like giving growth hormone. It's not going to get them this huge growth spurt, but it does make their testosterone levels a little bit higher. So I just warn them, they may get more acne, but they won't be the Incredible Hulk on you or go crazy. It's just, and I'll watch the testosterone levels just to make sure they don't get too high. But I usually end up using it for 1 or 2 years. Obviously, in women that have breast cancer, they're using it to decrease estrogen levels for breast cancer. But sometimes it's good. And then also my kids who are poor weight gain, also periactin, a lot of these kids with ADHD meds, their appetite tanks. And just ADHD meds in general, even on kids who still maintain their weight, the data shows that it does affect their growth. And so, but the ones who are not gaining weight well, especially during the school season when they're not off of their meds, if they'll take a break in the summer, I'll use periactin to help, kind of offset that, to see if I can just get some more calories in them, that they can grow a little bit bigger. And a lot of those kids are picky eaters, so it complicates it.
I think I read somewhere, is this correct or incorrect, that with ADHD meds, it may delay their growth in height during the pubertal growth spurt, but the end height is as should be expected. Is that correct or incorrect?
I mean, it's hard to say. I mean, part of it depends on like when they start puberty and their timing and like how fast those growth plates close. And like, so when they start, so that's where like sometimes the aromatase inhibitors are helpful, just to kind of buy me time again. I mean, I think it varies too, and just like how low their weight is, and how much less they're tracking below their mid-parental height. So if they go through puberty kind of early or normal timing and they're really far away from their mid-parental height, then I would be worried, that they won't meet that mid-parental height. And obviously, I mean, girls care, but the boys are the ones who care, care really big time, like how tall they are. They tend to be a little bit more self-conscious about it. And this was just an epic. I don't know if all EMRs, but they actually have a growth velocity growth chart too. So on this kid, as you can tell, like, for me, growth velocity less than 4 centimeters is my red flag. So if their growth velocity is less than 4 centimeters, I'm thinking like growth hormone deficiency or something else going on. So his was always above 4. And now that because his bone age was delayed and puberty was a little bit delayed because of that, you can see his growth velocity for his age is really high, but that's because his bone age is delayed. So, but it's still within normal range. And boys get their growth spurt like Tanner 3 to 4 of their puberty. Girls get our growth spurt like Tanner 2 of puberty, which is why middle school girls start puberty earlier. We make a lot of estrogen, so we get that huge growth spurt in middle school. All the boys are still kind of struggling behind us, and then we stop growing, and then they all keep growing in high school. So that's what I try to explain to my patients, especially the boys, because they, on top of the short stature, if they're behind in puberty compared to their peers, they also get very self-conscious, locker room talk, anyway. I'm not a boy, I don't know, but that's what they say. So Kate's 2. This was actually another recent patient of mine. So he came for short stature. So as you can see, both height and weight. The height is at that end. I mean, really just kind of always really tall and big, 90th percentile, and then just really kind of just stopped growing, almost flatlining for a while. And the weight fell off kind of at the same time. When mom came to the appointment that day, his height was at the 2nd percentile, weight was at the 44th percent. Mom also complained that he's had polyuria, polydipsia for years, and he has to wake up at night to pee. He wets the bed. He wakes up to drink at night. The pediatrician had screened for diabetes in the past, which was normal. He's tired a lot, headaches, but otherwise no GI symptoms, does well in school otherwise. And so my brain, I'm thinking, you're not growing and you're peeing and drinking a lot. Like, do you have I'm hoping you don't have a tumor just because it's been going on for a while, but I'm thinking, okay, this sounds like something central. Like this sounds like maybe diabetes insipidus with the increased thirst and urination and not growing. And so for him, labs and x-rays, bone age was 8 years. So it was only 1 year delayed. I was actually very surprised by that, given how long he had not been growing. Well, lab-wise, my initial lab, CBC, CMP was normal, celiac was negative, thyroid function was normal. So I was like, well, that's reassuring, but still very concerned by his growth chart. His IGF-1 was 43, so that is very low. And his IGF-BP3 was also very low. I usually do both of those levels. The IGF-1 is like the indirect measurement of growth hormone because growth hormone is secreted in pulsatile fashion. And so if you just measure a random growth hormone level, that doesn't tell me anything, or doesn't tell you anything either. It doesn't diagnose growth deficiency. The IGF-1 is like, it comes from the liver. And so and the growth hormone talks to the liver, and then the liver makes the IGF-1. And it's more stable in the blood. So it's that number, if it's low, then that's probably a sign you definitely have deficiency. If it's normal, that doesn't rule out deficiency. But again, in his case, my ears were already, just looking at his growth chart and his history, I already was kind of thinking, I'm going to do the growth hormone testing on this kid. The IGF-BP3, sometimes on kids who are like severe failure to thrive, both of those numbers will be low also. And so sometimes it can just be from malnutrition. So the IGF-BP3, if that's also very low, that can tell me sometimes it can also be something nutritional. So a lot of times with those, I'll try to get the weight up first before I go down the rabbit trail of testing for growth hormone. So I did the stimulation test. So when we do the stim test, we use 2 different agents to stimulate the pituitary to make growth hormone and then measure the growth hormone level at timed intervals. Normal is above 10. His highest he got was 1.7. So his pituitary was just not having it. So when he come in for the stim test, they have to be fasting. And so I said, okay, mom, do not let him drink at night. We need to see like what happens. It's going to be hard because he's been waking up every night. And she said it was miserable. He was up crying a lot of the night asking for something to drink. So that morning morning when he came in, his sodium was 148. So a little bit high, not crazy, but a little bit. But his urine osmoles were 149. So that's really low. Those should easily be above 300 in the morning, especially usually in the morning. If you haven't drank all night, like that would be probably like 600 or something like that. You should have really concentrated urine in the morning. And I did ask her on history, do you notice, is his pee ever like yellow? And she's like, actually, now that you ask, not really. It always looks kind of clear. So that's also in my head another signal that there could be diabetes insipidus. So I did his MRI. It did show a small pituitary. Now, he did have the pituitary bright spot. So for those who don't know, the bright spot is where the antidiuretic hormone is made. So if you see that in MRI, usually that's a sign that you do make it, but you can have partial DI. So you may be making it, but just not up to speed, which is evident. So when I did the initial labs and the sodium was normal, but he was drinking. He had been drinking all day when he came to the appointment. And so for a person who has an intact thirst mechanism, a partial DI, they can look fine. But if you fast them or they get sick and they have vomiting, then they'll come in hypernatremic. And so because I fasted him, he had mild hypernatremia. And so for him, I did, just for quality of life, I did start a small dose of DDAVP at night, mostly at night to help prevent all the nighttime waking and nighttime urinating so he wouldn't have accidents. And then we are starting growth hormone for his growth hormone deficiency. And so, and this will be another kid too that I will have to monitor cortisol. The growth hormone stem test, I also checked their ACTH and cortisol. His was normal. But if he has a small pituitary gland, that could mean other pituitary hormones may be affected down the line. His TSH and T4 were normal, but that will be something I will continue to follow. With there being a central issue, sometimes the TSH will look normal, but the free T4 is just continuing to drop down, which tells me that like the pituitary isn't able to keep up and, stimulate the thyroid gland. And so that's something I will keep a watch out for. And again, this evaluation, the big thing when you're looking at growth, one, making sure you have an accurate height and weight. This may not be everybody's clinic, but I know some offices, when they come in for sick visits, they don't always do a height. They always do a weight, but not a height. But then I think in some of y'all's EMRs, it makes the staff put in a height still. So they'll carry the height from the prior visit. And so then when you, as a pediatrician, just looking and you're like, ... they're all staying the same. If they only come in for sick visits and they're not always coming for their well checks, so then they'll refer for poor growth. And it just turned out that the staff wasn't putting in a height. And again, you don't really need the height every sick visit if they're coming every week for, a cold. You want the weight because if they have, need antibiotics, you can calculate your dosing. But anyway, I don't know, just something to think about. So if you notice it, you may just want to say, hey, did you measure them today? Because let's just make sure they're growing. And then also just looking height, weight what was dropping first? Was the weight dropping first or was the height, if the weight's dropping first, then let's think more nutrition. Again, are the ADHD meds? Do we need periactin? Do we need a CGI first? Versus sending to endo, because then I'm just going to send in GI if that's what I see on the growth chart, because I want to get that checked out first before I start barking down the tree of growth hormone deficiency. But if the height is dropping first, or they just always been short with a normal weight, then obviously, and then also asking, parents' height, and then obviously any other, physical exam findings, like I said, for girls, Turner syndrome, just being mindful of the, some of those characteristics. Again, not a lot of Turner syndrome. I'm diagnosing them 8, 9, 10, 11. I diagnosed one at 12 who was mosaic and was already having periods when she came. So again, they can kind of fool you. So when in doubt, just be mindful of those kids. Thyroid. So we get lots of thyroid antibodies. This patient was a 15-year-old girl, came for obesity, and she had TPO antibodies. As you can see from her growth chart, she's always been overweight. She really started picking up at 11, and in the history, her dad passed at that time. And so obviously gained a lot of weight with her dad's passing. She had a little dip right before she came and then had gained it back. And then also in the history, I found out we've been struggling with bulimia and eating disorder and body dysmorphia from that. And so a lot of things going on, but on the referral, it was TPO antibodies. And so they kind of the girl came in thinking, oh, you're going to put me on thyroid medicine and you're going to make me lose weight because of that. And so it was a long visit with lots of tears because it was like, just because you have the antibodies doesn't mean that you're going to need medicine. The PCP had actually done the thyroid studies and they were normal. So she had a TSH of 3.4 and a free T4 of 1.19. Still stone cold normal, but TPO was 338. The TPO antibodies in general really high doesn't necessarily mean it's more severe or that they're definitely going to get it sooner or later. And so, sometimes I'll get it where the TPO is like greater than 2000, but the thyroid function is normal. So in those patients, I'm not going to start treatment yet, even though the antibodies are very high. Sometimes the antibodies will give them an enlarged thyroid gland. And so, sometimes y'all will check ultrasounds before, that's fine. Usually it will kind of describe that Hashimoto's appearance of the antibodies attacking the gland. And so, for me, I don't get an ultrasound every person with Hashimoto's. Usually if I obviously feel a nodule or if one side's bigger than the other, even if I don't feel a nodule, then obviously that would be concerning. Or if it's just like really massive, like you walk in the room and can see it, then I'll get an ultrasound just to make sure I'm not, because then at that point, if there is a nodule way in the back, I'm probably not going to be able to feel it. So I'll get it, but I don't get it for every patient. And then I did repeat her thyroid function that day and it was still normal. TSH at 2.2 and the free T4 was 0.95. And so I did not start thyroid medicine on her at that time. And even history-wise, she didn't have a ton of like hypothyroid symptoms besides the weight gain. But obviously with the eating disorder stuff going on, I was like, we got to address that first and get that under control. But in this, I was just more so, you don't need to screen, like most people don't, but just... I know some parents will be like, check a whole thyroid panel and check everything because they go on Google or maybe their doctor, said something. So, and everyone is looking into alternative forms of medicine. And so the tendency is to check all the things. If there is a family history of Hashimoto's, then, sure, you can grab it if you want to. But it doesn't mean that they need treatment if their thyroid function is still normal. The other thing too is also just like, sometimes just screening the TSH. What sometimes happens is you'll get a normal TSH and a free T4 that's like 0.03 less than the reference range. That's probably nothing, honestly. Like I know our lab, for some reason with our peds ones, I feel like it's always a little bit low like that sometimes. And it's something with the assay and the way they're running it in the background. And so usually just screening with the TSH first. And then on top of that, obesity, sometimes they can have a mild elevation in their TSH. That's not true hypothyroidism. If it's like 5 point something or 6, and usually those you can just repeat and trend. And then maybe check the antibodies if you didn't the first time, just to make sure it isn't an early, evidence of Hashimoto's. And of course it's hard because everyone's is tired. So, they come in, oh, I'm tired. So then you ask sleep habits, they're on their phones until 2 a.m. So, okay, case number 2. So the other common one, and this one is, these are ones that we want you to refer for sure. Call me is hyperthyroid. So 4-year-old male presented with tachycardia to the PCP. He had been sick kind of back to back, had lost a little weight, but then supposedly gained it back according to the parents. But he went to the ER and they said, oh, you have a heart murmur. And he had never had a heart murmur before. So go follow up with your PCP. Went to the PCP. They heard the murmur and the kid was tachycardic, 120s, 130s. Referred to Dr. Cardis with Sibley Cardiology. And then he saw him in the office. He heard grade 2 systolic murmur, hyperactive pericardium, heart rate was 131, and he noticed a prominent thyroid gland. Dr. Cardis did the labs and called me in a panic. TSH was suppressed and the total T4 was 17, which is elevated. And so I saw him and then I ended up starting methimazole and the propanolol. But definitely for, any patients coming in with tachycardia, always on the differential, as far as checking the thyroid function. And those patients checking the TSH and the T4, is helpful in these, obviously. They don't always have a goiter. Sometimes they do. Sometimes they also have the bulging proptotic eyes. And so these are ones that need to be seen urgently. So those are ones where if you have my number, call me, call my office. I want to make sure we screen all of our referrals to determine urgency. But what if, somebody didn't fax it or the fax didn't come through or, since we review them, if they're at the bottom of the stack. And so these are ones that I just want to make sure because these can get serious, if their heart rate is beating that fast for a prolonged period of time and they're out running and playing on top of that. So these are ones that definitely just give us a call and we'll be happy to get them in. Sometimes I'll say, hey, if I give you the methimazole dose, do you mind starting it or at least starting the beta blocker, if it's going to be a few days before I can get them in. But we try to get these in as urgently as possible. And this is, again, just another little tidbits and thyroid algorithm. So best screen for thyroid disorders, again, TSH, unless you have a strong suspicion for like hyper or hypothyroidism, then you can check your free T4. And then for my hyperthyroid, I also check a total T3 in addition to my free T4. Mild TSH elevations, less than 10, normal free T4, especially in somebody that's obese, then that could just be related to the obesity. So you could just repeat it in a couple months, also grab the antibodies just to make sure this isn't, a sign of Hashimoto's starting. If they have obviously the low TSH, high free T4, then definitely refer to us, call us. Sometimes we have patients that will, like if they've been sick a lot, you may check it and they have a low TSH and a low T4. So that can be like a sick euthyroid. Those usually we just have to kind of monitor, but obviously those could be worrisome because then you're thinking something central is going on. So, and those ones like definitely, call us. I've seen a few lately that's a low TSH and a completely normal free T4. And, sometimes I'll just be like, just check it again and let's see. I don't know. I'm like, maybe they were sick recently and the TSH was a little bit suppressed, but there's been a few where I've seen them and I'll end up doing the MRI to make sure and it's all normal. So I don't know what's causing that. And for some of these, if it's an assay thing on the back end, but I do get that occasionally. So if you ever have something weird like that, everything in endocrine is a feedback mechanism. So you try to make it make sense and it doesn't always make sense. So please feel free to reach out when you have like any questions about weird labs. I always talk faster in person than I do when I practice because I thought I was going to be a lot longer than I am now. The last thing was diabetes. And so obviously we see lots of diabetes, type 1 and type 2. Obviously, since COVID, both have been on the rise. And with obesity, we see a lot of type 2. So this was a case that my PA actually saw in clinic recently. 14-year-old white female went to the PCP for frequent urination. They did a UA, had glucose, no ketones, and they did an A1C, and it was 7.5, and no sign of infection either. BMI was 96%, so she was on the bigger side, but played softball, very active, like more athletic build. So we all know BMI. I mean, it's a decent thing, but if they're athletic, sometimes it can be misleading if they have a lot of muscle. So they started metformin and then referred to us. And so then my PA saw her in the clinic and, just looking at her, he was like, I don't know, like, not really seeing, she didn't have a family history of type 1. I think they had some type 2s, in older people. But he's like, well, I'm just going to screen for the antibodies for type 1 just to, see. And so we did that. And, she did have family history of type 1. I forgot. I misremembered that. So her labs did come back and she had GAD65 and the zinc T8 antibodies, which is consistent with type 1 diabetes. So the zinc T8, that's a newer antibody. That one does have a higher propensity to develop type 1 versus like the GAD65. So we did end up putting a Dexcom on her, watching her sugars, and we ended up starting a low-dose, long-acting insulin. The thing right nowadays with obesity on the rise, it's hard to know now who's type 1, type 2. So, unless it's like morbid obesity, acanthosis, and it's like slam dunk for sure this is type 2. I'm like, just grab the antibodies to be safe. Because obviously if they have antibodies, they need to be on insulin. And, not that if they're obese, the education, we still need to focus on, educating about, nutrition and diet. But we also want to make sure that we get them on insulin and they don't go too long thinking, they're a type 2 and they're a type 1. Also, an insulin and a C-peptide level is helpful because if they're a type 2, then those levels should be high because they're, insulin resistant, whereas they're type 1. They may look normal, but like if you have, if you check a blood sugar, and the blood sugar is like 200 and an insulin is on normal and not high, then that's probably type 1, because if you were a type 2 and your blood sugar was that high, I would expect your insulin level to be really high too. And so that could be a clue that maybe it is type 1. And then if that was the case, those come back fast. The antibodies take, a while to come back. And then you could, if it's a type 1, then we usually admit all of our type 1s to start insulin. And then type 2s, we admit them if their A1C is over 10%. Because if their A1C is over 10, I will start insulin. There's a lot of education involved with insulin initiation, and it just makes me feel more comfortable, especially when people live really far away, to get the education in the hospital. Let me give you the insulin, see how it works, instead of doing that from home. And it's a weighty diagnosis, and it's a lot for the families to absorb. But, before we used to look at a kid like, oh, you're skinny, you're type 1. Oh, you're overweight, you're type 2. Like, it's no help anymore. And family history is hard too, because a lot of people in South Georgia have family history of type 2. And, obviously if there's a history of type 1, then obviously, you will be concerned about that. But just to have that in your back of your head, I had mentioned earlier about me speaking for Sanofi. Part of that is because they do have, a push now to screen more, because we actually can do something about it now. So there's a drug came out about 2 years ago. It's called Tzield. It's a monoclonal antibody. So they have 2 antibodies for type 1, and they have dysglycemia. So like a pre-diabetic A1C, or, if you do an oral glucose tolerance test and they're in that dysglycemia range, which is like above 140, but less than 200, then they would be eligible for the infusion. It's a 14-day infusion. So they do get it every day for 14 days on an outpatient basis. Like we do it in the infusion center and then they go home. But it delays onset of stage 3, which is like, full-blown type 1 diabetes. And so in the studies, they did see that placebo, they developed type 1 within 2 years of seeing the antibodies were positive, whereas the people that got the drug on average was 4 years after infusion. But many in the study are, 7, 8, 10 years out from infusion and still have not developed diabetes. And then in some of their original studies, they were actually giving it to kids like just diagnosed with diabetes, and they were giving it, and it kind of pushed them into that honeymoon period. So they were able to kind of scoot by for a while without using a lot of insulin, which is still helpful. If you can get by on long acting only and not have to like do, multiple daily injections and wear a pump and all that, that's, helpful. So I just like putting it out there. They actually, now I'm blanking on the name, but there's a kit now that it looks like a newborn screen. Like you poke their finger, it has the little dots, you put the blood spots on it, and you mail it in. Enable Biosciences is who makes the kit, but that screens 3 of the 4 antibodies for type 1. And it will just bill their insurance. If there's a family history of type 1, like if one of their siblings has it, you could screen them, or if their parent has type 1. And then in my clinic, we've been starting to give out the kits so that my patients the parents can check the siblings. And also type 1 happens a lot in adults. A lot of adults are getting diagnosed with type 1. Again, the assumption is they're type 2, and then, they may go to an endocrinologist, and then, they're on all the meds for type 2, but still getting worse control. And then somebody will find you the antibodies and figure out they have type 1. So it's actually statistically diagnosed in adults and above 20 more than it is under 20, but we still consider type 1 a pediatric disease, but it is actually right. Like we see it diagnosed in adults very often too. So just something to have in the back of your head. I know there's lots of things in our heads, but the antibodies, so the GAD65, the zinc T8, the IA2, and then the insulin antibodies. And then, like I said, the insulin, glucose, and a C-peptide also can give you like a little clue in there. So questions I will take. And then I just put all these little pictures. The one with me and 3 little children, those are all my patients who, the patient with Down syndrome, he's also got type 1. And so he is our Children's Miracle Network, sponsored child, like poster child for the year. So all of the, like our local advertisements for Children's Miracle Network, he is on the posters. And so, he is a joy. He came to diabetes camp, to Camp Kudzu, and he will tell you he loves singing and dancing. And now when he sees me, I'm the doctor from Camp Kudzu, not the doctor who's been caring for him the last 6 years. But and then the other 2 kids, their brother and sister, and they were also one of the children chosen this year to help, just the little girl has type 1 and the little boy has pituitary issues and sickle cell. So they're all treated at our hospital. And so it's just, I was very excited. There was 5 kids picked and 3 of the 5 were my patients. So I was very excited this year. Middle picture up top, Dr. Basat. So probably everyone knew Dr. Basat. He was here for 36 years. He retired in December, for those who do not know. So if he didn't tell you, don't text him, because he doesn't work there anymore. So that's why I said, if you need my number, come get it from me. I did get a new partner, Dr. Velasquez. He was in Savannah. So depending on where you're from, if you were referring to Savannah, he's no longer there. He is here with us. And so you can send him our way. And he's been out of training for 4 years. So he was there in Savannah solo. So when he left, his practice closed. And so there is one private guy there, but obviously he can't see everyone. So, and then the 2 little girls are my children. Dr. Basat gifted my 3-year-old 3 months of ballet. And so then I had to get her in the recital, and he came to her recital the other weekend. He's like, it's like his adopted grandchild. And then that's me in the insulin syringe at Camp Kudzu, because we give out golden syringe awards for part of our education at Diabetes Camp is getting the kids to do diabetes things that they're not already doing. So if they haven't put a Dexcom on, if they've never given a shot, if they've, whatever new skill. And so when they do a new skill, every day we give awards out, we dance, we sing, make a tunnel, and one of the providers or volunteers dresses in the golden syringe, and we give them a little pin and a little certificate. So, and that's my family. We were at family camp for Camp Kudzu, and they rode we did paddle boating. So my kids got to join in diabetes camp too. So, but yeah, any questions about any of the cases, any other random stuff, I'll take it now, or I can talk after. So thank you. Yes.
What's the youngest that you diagnosed type 2 diabetes?
Type 2? Actually, when I was in training, we actually had a 5-year-old. We diagnosed with type 2, Hispanic. Both parents had it. The sister was diagnosed at 12. And that's one of my publication I did in fellowship, because at that time was like the youngest we could see in the literature. And we also tested all the type 1 antibodies to rule that out. And we also did his screening for MODY, maturity onset diabetes of the youth. We tested that to make sure we weren't missing that either. And it was just true, but he was morbidly obese. Here we've had some like 7, 8 years old. Again, usually very morbidly obese to be diagnosed that young. Usually type 2, you expect it to be like they've already started or in puberty, like post-pubertal, but I've had a few. And then I have one boy who has Prader-Willi, and I diagnosed him at 7, but he's got Prader-Willi and he's morbidly obese. So obviously that, caused it. Yeah. Yes.
Do children with type 2 diabetes have the same complications that adults do, like cardiovascular and skin disease?
Yeah, so children diagnosed with type 2 are actually worse off. So because usually type 2 20 years ago was a disease of adults. Like kids were not getting it. And so the fact that they're getting it so early, the research shows it's a more progressed form of type 2. So they're tending to have complications earlier. So they're getting complications in their 20s and 30s versus, if you were getting diagnosed in your 40s and 50s, you were already older when you were getting all the complications. And so, and they tend to have more issues, actually cardiovascular, lipids, hypertension tend to be worse. I don't see like the diabetic retinopathy. I honestly I'm bad sometimes about reminding my type 1s to do it because we just don't see it in the type 1s, but a type 2 at presentation, they can already have retinopathy. And then also like kidney, microprotein in their urine can be seen in type 2s right at diagnosis, because oftentimes, especially if they weren't going to their pediatrician for their well child checks to get that A1C, by the time they're diagnosed, it had been probably going on for a while. And so a lot of that damage has, already been done. So, these, and then especially in females, then all the risk for, with pregnancies and things like that. Actually, was right before I came here, I was at a meeting with our Diabetes Healthways, which is our outpatient and inpatient diabetes education in the hospital, their medical director, and they do a lot of gestational diabetes. And they were telling, just the number of gestational diabetes is insane. And, the rates of obesity associated with that, they were like, yeah, probably the smallest person's probably like 250 pounds. So just the level of obesity and gestational diabetes, like every year their numbers keep going up in that department. So just all these girls with type 2, just the high risk, for that too, is worrisome. Yes, Brittany.
So I will get requests sometimes from parents, mostly boys, but to check their hormone levels if they're angry or if they're emotional.
Yes.
How do you respond to that?
Honestly, I kind of tell them if I do my exam and they're not in puberty, I'm like, the hormone levels aren't going to show me anything. I had a mom, the kid was, he had early puberty. We had treated for that, but it was time to come off the meds. But sometimes with the boys, it's like the hypersexuality. And I'm like, even if I treat it, they're probably still gonna, they're still gonna, have some of those, things that they're doing that may disturb you, but some of that's just natural child development. And I get that with girls too, they're emotional, and I always get checks the whole hormone panel. I don't know what that means. I don't know what they mean by that. There's a lot of hormones, but like if you don't have signs of puberty, then me checking the puberty hormones are not going to be like the magic. So I mean, besides maybe checking a thyroid, but usually even then I'm just like, it's not going to. I mean, we're just going to stick your child for nothing. Like, I mean, I think a lot of it is probably just like, what's going on at home, what's going on at school, like let's dig in more to probably mental health, and then some of it is just, I think, natural. Like I have a 9-year-old and a 6-year-old. And so I feel like the 6-year-old girl, I feel like is always crying about something. And I'm like, I think this is just, I look, there's no signs of puberty. Like, I just think that it's just the normal thing. But I try to tell them, like, if I stick them, I'm not going to, nothing's going to come out of it. So I think it would be like an extra poke that they, will be one more thing they're going to cry about and be mad about probably. So.
Especially the teenage boys that are going through puberty.
Yeah.
They're like, they're so angry that,
Yeah.
I try to tell them it's crazy.
Yeah.
And they want me to test something, but I understand it's very fun.
Yeah, I mean, even if you check a testosterone, like if it's normal, like you're not, or if it's even a little bit higher, I mean, you're not going to stop their puberty. You're stop your puberty at that point. So yeah, I mean, I think honestly, I feel like it's a symptom of our culture of just like wanting a quick fix for everything. And like, I have to have a reason why, it's just like, maybe just go talk to a counselor. Honestly, like it's probably more mental health, like what stressors are going on at school, what's going on at home. So that's my opinion. So, yeah.
When do you recommend that we do this antibody test when we have this abnormal hemoglobin A1Cs?
I would say, definitely if you have a patient that, if they're not obese, and I would definitely check them for sure. And unless, I would say just like anecdotally from my experience, like Hispanic, just because genetic predisposition, Hispanic and Black children, I tend to notice, even just a little bit overweight, I will see type 2, and we'll screen for type 1, especially if their A1C is above 10. If their A1C is above 10 and they come to the hospital, I'm screening for type 1 because I don't want to miss that. Even though I'm going to start insulin anyway, I just want to make sure I don't take it off if they really do need it. But where have I seen where like I'll have, Caucasian patients that like, I had this one kid I remember a few years back, he was 300 pounds, dad was type 2. All of them were obese. And so in my brain, I'm like, he's for sure going to be a type 2. And then antibodies came back all out of the roof. So I was like, okay, well, it got me. So in general, again, like I said, if it's like a slam dunk, you have a 10-year-old that's 250 pounds with acanthosis, it's like, okay, yeah, and then you can do the insulin and C-peptide. And if those were elevated, then, okay, you don't need to go back and check the antibodies because they're expensive. And, but if they're not overweight, definitely I would check it. And then if they do come back positive, then those are ones, like I said, we would just admit them, for education and training. And those are like, if you call us, we'll just like, we'll get you to call the transfer center and, they don't have to come through the ER. If you did labs recently, we know they're not in DKA, then we can just direct admit them, to our children's hospital for education. Yeah.
So with your younger population, like you gave the example of the severely obese child that had diabetes, do you have any success prescribing like the injectable?
So for the GLPs, they'll mostly it's 10 and up. For Medicaid patients, they won't cover anything just for obesity, only for type 2. And the A1C has to be above 7%. So if you're catching it early, they still won't cover it. So for the younger ones, I kind of have metformin and insulin if their A1C is that high. And then once they get older, and I will say, honestly, the Medicaids are getting even worse that they were covering Trulicity, which is once a week, and it works okay. I don't see the great weight loss on Trulicity like you do like Ozempic or, but now most of them are going back to only covering Victoza, which is once a day. And honestly, they do not lose weight on Victoza ever. And probably because they're not taking it, honestly. And it kind of helps their diabetes, but honestly, not really. And so it's kind of unfortunate because I'm like, I know Victoza is cheaper, but still probably expensive, so it's like, why pay for that when you could just pay for something a little bit better and would get better results? But, that's Medicaid. I try to, when I can talk to people on the phone at like Peach State or any of those, I try to figure out what who's making decisions and what is this based off of? But I never really get answers. But yeah, the coverage now, I will say in private pay patients, not, young, but if they meet the age requirements, some plans I can get stuff covered for obesity, the GLP ones, like Wegovy or something on the private plans. But even now I've noticed some of the private plans, obesity is it's a plan exclusion. So even the adults can't get it for obesity. I think it's just because they're getting popular and they're expensive and the insurance companies don't want to pay for them. But yeah, it is hard to get them. And then on our end, for even our diabetics, there's so many prior authorizations. Even if it's on the list, you still have to do a prior auth and they'll deny it and then you have to fight back. So it's annoying. Sorry, I'll go here because she hasn't asked a question yet. Dr. Mountner.
We usually order a free T4, total T4, and a TSH. I used to order the T3, and then I went to a CME. They said not to do the T3. Yeah. But I'm getting back a lot of normal free T4s, normal TSH, but elevated total T4s. And they're obese. So I'm trying to see, should I refer to endo or just the obesity is causing the total T4? Because I know that's bounded versus
Exactly. That's what I was going to say because of the bounded. So
who should I refer if I get elevated total T4 but normal TSH and free T4?
I would say stop checking the total T4. I'm not trying to be funny, but honestly, because it's the bound and unbound, and so. If they have a normal TSH and if you said obesity patients, so they're gaining weight, not losing weight, they're not acting like they're hyperthyroid. So I usually like TSH or TSH and free T4. Unless I think they're hyperthyroid, I will grab the total T3 because sometimes with hyperthyroid, the TSH will be suppressed, the free T4 will still be normal, but the T3 will be high. So, I usually don't check the total T4 regularly. And that's similar to on the newborn screen, the total T4, it can flag low because if they have the TBG deficiency. And so the total T4 will be low, but the free T4 and the TSH is normal because they're not making the TBG. And so that will always look abnormal on those kids. So, the free T4 to me is that's what's unbound. That's what's I say more active. Really, it's T3 that's doing the major work. But so usually I just do TSH. And if you're just doing a general screening, then I would just do TSH. You're welcome. Did you? Somebody? I know you.
When you come to an obese patient with pre-diabetes, do you go ahead and start him on metformin?
It varies. I try. I would try. Obviously, to diet modifications first, exercise, lifestyle modifications. If you've already done that and it keeps creeping up, it's not diabetic yet, but it's slowly creeping up, then a lot of times I will. It's I always get caught sometimes. I also don't want, again, that mentality of just give me the pill and I don't want to make the changes. Because at the end of the day, if you don't make the changes, I can give you the pill, but I'm just going to keep increasing it. And then we're going to still end up on something else. So, but some of those patients, and again, because of the patients that we're serving, they don't always have access to, good food and places to exercise. And, they eat the school food, which isn't always the best either. So in that respect, sometimes it's if I can buy them time to not be diabetic, then I'll just, start the metformin. We tend to, just because if we saw every obese child in Middle and South Georgia, we would only be seeing obese children and not being able to see all the other stuff. So in general, we say if the A1C is 6 and above, and we'll see those referrals because we're getting closer. If it's just obesity and, maybe 5.7 or even normal A1C, but the obesity, then here at Atrium, at our Children's Health Center, we have our Healthy Me Clinic. We have a nutritionist that works with them. So y'all can always refer, to them for nutrition education and further along and kind of monitor for that. But in general, sometimes I do just bite the bullet and start it. Some parents don't want it. Some parents, I took metformin and, I had these side effects. If I do start it, I usually try to start only at 500 once a day and even maybe consider doing the XR just so they don't have all the stomach diarrhea and stomach aches from it because then they never want to take it again. They are diabetic and now they refuse to take it. So. Did you have another one?
Last question
Yeah.
for me is, I have a 5-year-old patient who came in this week, and he's been my patient since birth, and he was caught on the newborn screen to be hypothyroid. Truly hypothyroid, and diagnosed 4 days of life, started meds at 5 days of life. Currently in kindergarten and having some behavior issues with aggression. And the mama asked, could there be any correlation between the hypothyroid and that diagnosis and this behavior? And I didn't know if you caught it that quickly and started meds. I'd say unlikely.
Yeah. I mean, the only thing I could think of, which probably wouldn't, but like, unless his dose is too high and he's like hyperthyroid and feeling anxious and jittery, but like, yeah. So I would say probably not. I mean, most of my patients, especially if they were caught that early and they never, there was no like concern for, especially if he's not developmentally delayed otherwise, then yeah, I wouldn't think there should be any correlation. But yeah, the parents are worried. I mean, it makes sense. But so most of my patients that we catch early, they do well, they grow well, and they function completely normally. So especially if they've had normal life, if they've been in control that whole time, and especially I would think too, if they don't have any other, they're not struggling in school, or, they weren't behind on their talking and things like that, then I doubt it would just be, just aggression. It's probably just the age and maybe some play therapy. Yeah. I think that's my time anyway, 3:00. So, but thank you, but I'll be around if anybody needs me.